Wabarakatuh. Welcome back to my YouTube channel. I am Dr. Dada, and today we are going to continue with the most common GIT presentations, which is the part 4. And I am going to discuss the upper and lower GIT bleeding. Okay, let's dive in and see. So GI bleeding, which is the gastrointestinal tract bleeding, it's bleeding either from the upper GI tract or from the lower GI tract. Okay, this GIT bleeding is divided into two. We have the upper GI bleeding and we have the lower GI bleeding. Let's correct this, please. Lower. Okay, and we are going to discuss one by one, and I'm starting with the upper GI bleeding. Now, what's the definition of this upper GI bleeding? This is what bleeding from the esophagus, stomach, and duodenum, which can present either as hematemesis or melena. So upper GI bleeding is the bleeding from the esophagus, stomach, and duodenum, which can present as hematemesis or melena. Now, let's see. What is hematemesis? Mesis is what? Vomiting of blood. While melena is passage of black stool, which is just passing of blood through the stool, so making the stool black in color, because it is upper GI bleeding, not lower GI bleeding. Already metabolism takes place and the rest, so changing the color. All right, now let's see what are the causes or etiology of upper GI bleeding. Okay, we have esophagitis. Well, it's one of the cause, inflammation. And we have peptic ulcer, which is the most common cause of upper GI bleeding. If you can remember, I told you the same thing when I was presenting peptic ulcer in our previous video. Okay, and we have vascular malformations too. Vascular malformations, and we have gastric erosions, varices, and biliary tear due to excessive vomiting. Okay, now what's the clinical picture of upper GI bleeding? I've said it earlier. The thing is hematemesis, hematemesis, melena, which I told you the meaning earlier too. We have anemia. You know, the person is bleeding, so definitely anemia. And syncopal attack, decreased urine output. When it is severe, the person goes into shock. So, how do you investigate patients with this kind of problem? Investigations. Number one, you do history and examinations. Number two, you do endoscopy to know the source of bleeding. You do blood tests, which includes the LFT, PT, blood grouping, etc. And you do also angiography. You can also do urea, creatinine, electrolytes. There is also radionuclide scan. You are not going to do all of this at the same time. It depends on what you get from your history and examinations. Okay, so now how do you manage patients with this kind of problem? Management. What you do is, number one, you resuscitate the patient. Resuscitation and then oxygen. Yeah. And you can do therapeutic endoscopy, which includes 3 things you can do: either cautery, sclerotherapy, or banding. And now, then you can do eradication of H. pylori, if it is positive. And now you can monitor your patient. And if the bleeding is severe, you do surgery. We have some indications for surgery. Let me tell you. We have severe bleeding. Number one. And we have rebleeding after the treatment. And we have bleeding which is non-responsive to resuscitative measurements. So these are the indications for surgery, and we are done with the upper GI bleeding. Now let's dive in and see what is lower GI bleeding. Lower GI bleeding. So by definition, lower GI bleeding is the bleeding from the lower GI tract, or bleeding from intestines intestines, that is below the ligament of Treats. Intestines, we have also the colon and the anal canal. Bleeding from the intestines, colons, and the anal canal. The presentation is hematochezia. Now, what's the etiology of this lower GI bleeding? Etiology. We have 3 classifications. Here. According to age, according to pain, and according to severity. Now, according to age, if the patient is less than 50 years, we have anorectal diseases like hemorrhoids, anal fissure, etc. And we have infectious colitis like the Shigella. We have IBD, which is inflammatory bowel disease. Now, if the patient is more than 50 years, we have things like diverticulosis, and we have angiodysplasia. We have neoplasms. This is especially if an elderly presents to the hospital with lower GI bleeding, you must exclude neoplasm. And the last one is ischemic colitis. Where am I going to write this? Ischemic colitis. Okay, now according to pain, we have bleeding, those that bleed with pain, things like the anal fissure. So there is bleeding and the patient will tell you there is pain. We have ischemic colitis. We have IBD, the inflammatory bowel disease. And then the painless bleeding. We have the hemorrhoids. We have diverticulosis. And we have angiodysplasia. Now, the next one is according to severity. We have severe acute, severe plus acute. Okay. Under this, we have diverticular disease. We also have ischemia. IBD is always there. We have angiodysplasia too. And we have Michel's diverticulum. Okay. Now, the ones that are moderate or chronic or subacute. The second one, moderate, chronic or subacute causes, severity. So we have things like the fissure, polyps, large polyps, carcinoma, hemorrhoids, angiodysplasia, radiation enteritis, and finally we have the solitary rectal ulcer. Okay, so these are the etiologies according to age, according to pain, and according to severity. And like I said earlier, the presentation of lower GI bleeding is hematochezia, which is bleeding. Now, how do we investigate patients with lower GI presentation? Investigations. We have history and examination. It's always there. You do endoscopy and sigmoidoscopy. And you exclude upper GI bleeding. You do angiography and colonoscopy. Well, you are not going to do all of this at the same time. You choose according to your findings or according to your patient. And how do you manage patient with this problem? Management. We have number one, we have bed rest, sedation, and transfusion. If the patient is on aspirin or other NSAIDs, you stop the medication. You stop the risk factors in general. Stop risk factors and therapeutic colonoscopy. You can do also intra-arterial vasopressin or embolization. And finally, surgery. Now, this brings us to the end of upper and lower GI bleeding. Alhamdulillah, thank you. And I hope you are enjoying my lectures. Kindly like, share, subscribe, comment, and turn your notification button. Ding 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 ding. So, dada.